Welcome to our vodcast series on shingles. The goal of this six-part series is to increase healthcare professionals' understanding and awareness of shingles, strive to reduce healthcare disparities and inequities, and improve healthcare professionals' performance and enhance quality of care for patients. During this fifth episode, we'll discuss patient-centered and clinical strategies to overcome barriers and inequities in shingles vaccination, with a focus on system-based interventions that improve two-dose Zoster series completion. As we get started, I want to mention that this is an educational activity and it's supported by the Independent Medical Education Grant from GSK. Recommendations and opinions presented may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement of any product, device, or instruction. I'm Karen Larmer. I'm a nurse practitioner and researcher. I work at a company called CardioSense, and I specialize in heart failure and digital health, but I'm also a longtime volunteer for the American Heart Association. Dr. Han, could you introduce yourself?
My name is Zheng Han. I'm an associate professor of pharmacy practice at the Massachusetts College of Pharmacy and Health Sciences in Boston. I am also an infectious disease clinical pharmacist at the Boston Medical Center South, where I oversee pharmacy students on their internal medicine and hospital pharmacy rotations.
Dr. Han, thank you so much for being with us today. And I'm going to also introduce our second panelist. Dr. Rindle, could you introduce yourself?
Absolutely. I'm Dr. Sarah Rendell. I'm a board-certified physician in internal medicine and a clinical fellow in infectious diseases at Massachusetts General and Brigham and Women's Hospitals in Boston. I focus on the prevention and treatment of chronic infections.
Well, it's wonderful to have both of you on this podcast today. And what I'd like to start with is talking about some of the barriers that patients might face when considering getting the vaccination. The focus of our discussion today is going to be on those barriers to receiving the shingles vaccine. To start, let's talk about cost of the vaccine. This is a common perceived barrier to receiving the vaccine. We know that complex insurance structures, particularly the distinction between Medicare Part B and Part D, create significant confusion for patients and for clinicians. Uncertainty around coverage, out-of-pocket costs, and access pathways can delay treatment initiation and contribute to non-adherence, especially for underserved populations. Addressing these gaps is critical to ensuring timely evidence-based care like when, where, and how to receive the shingles vaccine. Dr. Han, I'm going to turn to you. What strategies can healthcare professionals use to address confusion about cost and insurance coverage, especially around Part D and Part B Medicare?
Yes, indeed, cost is a significant barrier to receiving the shingles vaccine, especially for the uninsured or underinsured. For Medicare patients, coverage can be also quite confusing. The shingles vaccine is covered under Medicare Part D with a $0 copay, or under certain Medicare Advantage plans with prescription drug coverage. But in order to enjoy the benefits of $0 out-of-pocket costs, patients will need to receive the vaccine from an in-network pharmacy rather than from their provider's office. The vaccine is not covered under Medicare Parts A and B. So this presents a significant issue. Some organizations have leveraged electronic health records to build alerts that facilitate the screening of insurance coverage and referring Medicare patients to receive the vaccine at their local pharmacies or at the outpatient pharmacy if the organization has one available. Providers, offices, or clinics may also undergo a formulary exception process for patients who have extreme difficulty due to underlying medical conditions, making it difficult to receive the vaccine at a pharmacy in order to obtain the vaccine series at the clinic instead.
Very interesting, Dr. Han. Thank you for that. Also, let's talk about another barrier to receiving the vaccine, and that's fear of side effects or getting an injection in general. What would you recommend as the best practice for responding to patients that have fear of side effects or an injection?
Yes, many patients have heard about side effects associated with the shingles vaccine, namely fatigue, fever, and injection site reaction, which can at times make patients hesitant to receive the vaccine. And their worry is not unfounded because the shingles vaccine is known to be reactogenic in nature. And reactogenicity is a term that we use to refer to how a vaccine is expected to cause short-term symptoms after administration. And in the case of shingles vaccine, approximately 80% of patients experience short-term symptoms like fatigue, fever, or injection site pain after administration. And this reactogenicity has to do with the presence of the AS01 adjuvant, which is present in the vaccine to boost its immunogenicity. That's a really great thing, but unfortunately, it is also responsible for the common side effects associated with the vaccine. In clinical trials, we know that most patients experience these side effects for about 2 to 3 days. But in practice, I think most patients do say that they experience the side effects that resolve on their own for about a day. So as providers, it is really important to manage and normalize patients' expectations when we recommend the shingles vaccines. We often like to tell patients that in a vaccine, it is the antigen that we want our immune system to learn to recognize and protect us against. And think of that antigen as something that the immune system will need to learn to read. And the adjuvant that is present is almost like reading glasses that helps your immune system read better and learn more effectively for the long term. So in the short run, you may have pain or a little bit of a fever, and that is all normal reaction as your immune system learns to protect you. These side effects usually last for about a day or so, and then you'll be back to where you began. Some patients also fear that they could get the shingles from the vaccine itself. This is not possible because the shingles vaccine that we now have on the market is a recombinant product, which are laboratory engineered products containing only certain parts of the virus that are not possible for causing the disease itself. This is very much unlike the old shingles vaccine, which contain a weakened form of a live virus, which theoretically can cause the disease. The live attenuated vaccine is no longer in use commercially.
That's great to know. Very interesting and so helpful to our patients. Um, let's now talk about what steps we can use to reduce logistical challenges like missed second doses or limited vaccine availability in rural areas, for example.
Yeah, I think patient education is really the key in addressing the issue of missed second doses. When the first dose is administered, really counsel patients on the appropriate window that they need to receive the second dose. And it helps to give them an exact time frame. So say if they are getting their first dose right now in March, let them know that they should be getting the second dose sometime between May to October. And that's usually more helpful for patients rather than giving something generic, like between 2 to 6 months. Preferably have patients schedule the appointment for the second dose, give them an appointment card or send them some form of electronic reminder. Additionally, physician offices who see a large population of older patients or immunocompromised patients can also work with their local community pharmacies.
Thanks, Dr. Hahn. That's all such interesting information. So I'm going to turn now to Dr. Rendell, and we're going to talk more about these barriers and strategies for assuring that patients are well informed and able to get the vaccination series. So Dr. Rendell, how do we support patients through this entire vaccination process? How can healthcare professionals provide this patient-centered counseling about the shingles vaccine in an effort to build trust and that our patients feel supported?
And this is such an important topic. And honestly, one of the greatest privileges of being a clinician is that we get to sit with a person, sometimes multiple people, and ask the patient in front of us, what's important to you and how can I help? And so this should structure every visit, including visits when we give counseling about the shingles vaccine. And then you can tailor your approach to what matters to the patient. If a patient's trying to stay out of the hospital, then I recommend discussing with them how getting the shingles vaccine series is a strategy to protect them from hospitalization and severe complications from shingles. If a patient really values sleep and is struggling with sleep, I would talk about how we can protect them from post-herpetic neuralgia because the vaccine is more than 90% effective against that, and post-herpetic neuralgia interferes with sleep. If patients are just trying to keep going about life and they actually feel like things are going well, I'd like to assess for what responsibilities they have and burdens, and think about how we might, through a multi-pronged approach, prevent any diseases, including herpes zoster, that could interfere with their obligations like work, caregiving, travel. Because to us, an ED visit that lasts a day or even overnight might not seem like a lot, but that's hours of a patient's time, including in the waiting room. And sometimes that's just too much. So the shingles vaccine is one tool we have to keep people from having a predictable illness affect their life. Now, in terms of helping patients feel supported, this is very important for all things vaccines included. And I would say that one of the main ways, as Dr. Han already addressed, is to focus on and address accurately concerns about reactogenicity. Patients are sometimes worried about what will happen in the next day and how they'll be able to manage. And so we offer the vaccine on a day when they don't have major obligations the following day. I would not give it to a patient who's planning to give a very important talk or who is having a graduation party for their grandchild, because that might lead to some disruption. So really knowing what's happening in their life. And then finally, I cannot emphasize enough how important it is to seek a formulary exception to give the vaccine in clinic for people who cannot make it to the pharmacy. Pharmacies are not all accessible to people depending on their transportation needs and their mobility needs. And I've had success with getting formulary exceptions. This is something we can all do. I know that it's hard to add something to our labor, but it's worth it for a patient if they prefer to get it in the clinic and they have a reason to do that. We should support them in that preference.
The interesting perspective. I really appreciate that, Dr. Rendell. Let me ask you now about the techniques that healthcare professionals can use to clarify common misconceptions about shingles vaccine. It's really about more information, but not only that, accurate information. So can you share some more about that?
Yes, fortunately, we're in a time where so much information is available so quickly. Unfortunately, we're in a time where we cannot count on information to be accurate or even not harmful. So I think the most important technique is listening, because if we openly allow patients to share what they're worried about, we can address misconceptions that they do have and not add worries about things that they're not really concerned about. So I would say, I'd like to offer you this today. This is why. And then I say, please, let's talk about this and what you think. So some people say, oh, well, I've already had shingles, and so I don't need the vaccine because it won't happen again. That's a common misconception, and I wish that were true, but it's not. As we know, and as we've discussed in prior episodes, once you've had shingles, the risk of a recurrent attack is high, especially in people who have multifactorial diminishing of their immune system, both from age, diabetes, or even like a short steroid course. So I explain why that isn't true, and tell them that having had a zoster episode is all the more reason to get them vaccine protected against the next one. Some believe that the vaccine can cause shingles, and Dr. Han already talked about this, but this does reflect earlier experience with live zoster vaccine. And so it's important to explain to patients the differences between the recombinant vaccine and why that's no longer even a theoretical concern. And also, it's an opportunity to teach them to recognize what shingles is and looks like and what is not shingles, because patients are sometimes the first person that other people in their life reach out to understand what something is. And even if they don't get shingles themselves, it can be helpful for them to be educated and recognize it. Some believe that the vaccine is contraindicated in those who are immunocompromised. That is probably a holdover belief from a time when the Zoster vaccine that we had available was live. In fact, the recombinant Zoster vaccine is recommended in immunocompromised populations 18 years of age and older, and that's because it's especially important to protect them. It's a recombinant vaccine and is not associated with harms in immunocompromised populations. So I clarify that, and I spend extra time with my immunocompromised patients in discussing that. Some believe that the vaccine cannot be given if you are around children or immunocompromised people. And this is such a pro-social fear because the patients are not wanting to cause illness in someone else. And so I first celebrate the concern for others because it's important that we always think about how our health or what we receive or take into our body could affect someone else. I touched on this before, but there is a lot of confusion, not just generated by patients, but also by clinicians about the age cutoff for the recombinant zoster vaccine. 50 years of age and older is true for the general population, but 18 years of age or older is true for patients who have immunocompromising conditions or are planned to become immunosuppressed. For example, people who are listed for solid organ transplant. And we had a discussion of this before in the second episode of the series, and I'd also refer you to CDC guidelines for this vaccine.
Great information, Dr. Rendell. So we've talked about shared decision-making and patient-centered decision-making. And so, Dr. Rendell, can you talk about how can shared decision-making be applied to emphasize the risks of not vaccinating and the benefits of completing the series? Of course, we don't want to shame the patients, but there's techniques to this process of shared decision-making. Can you talk more about that?
Yes, clinicians are motivators. It's what we do. We motivate people who need a statin to take the statin. We support them in doing things that may be inconvenient or may not be super fun in the moment, but have an impact in the long run, and that they'll be grateful that they did later on. So I would say that when it comes to getting the recombinant zoster vaccine, shared decision-making is important. And as I mentioned before, once you've elicited what matters to somebody and what they're worried about as well, you're able to join them in their concerns, mirror their feelings about them, and also, based on what they prioritize, share the information that we have from the experience we have taking care of patients on why you're making this recommendation for this patient. I avoid saying things like, we give this to all people at age 50, without focus on the patient in front of me, because people can sometimes feel like the details of their individual life are lost in a statement like that. So instead, I say, today, I want us to talk about protecting you against shingles. You're now at risk of shingles, and it's going to continue to increase from this point on. Even healthy people get it, and often people have no warning. It can take time to recognize that it's there, and sometimes there can be a delay in diagnosis or treatment. And even with treatment, you can have pain. So after sharing that, I ask what they have heard about shingles. Most people have had a friend or a relative who's had it. And then I say, for these reasons, and I list out accurate, true reasons that I stand by for the patient in front of me, I would recommend that we get you the first dose of the shingles vaccine today, and we schedule the next one in about 2 to 6 months. And then, we spend time, patients usually know they have an open invitation to bring up objections or say they're worried about something. And part of the shared decision-making is planning around the reactogenicity that Dr. Hahn mentioned. So I say, are there any important things coming up that I should know about where you can't have a sore arm or a fever or be feeling under the weather? And then we brainstorm together about when would be a good time to schedule it. So that's what I would say. And in terms of risks, I do get consent first because we don't want to feel like we're scaring people all the time. But I'd say, is it okay if I share what I worry post-herpetic neuralgia could do for you? Or is it okay if we talk a little bit about how important your vision is and X activity that you perform and why I want to protect it as much as I can? And that way you have people's consent, and then you can talk a little bit about the things that we're hoping we never have to face together through giving them the vaccine.
So helpful, the tips and ways that you framed that information. Let's turn a little bit to how we work in different clinical roles and what it means for this particular intervention, the vaccination. It can have a bit of a challenge to it because it's a two-part vaccination, and anytime something requires a part B, we hope that actually happens. So let's talk about how can Dr. Rendell, how can healthcare professionals identify and address gaps in patient follow-up for that second dose that's so important?
Yes, and this is very much a team activity. The first time we talk about the vaccine, I get the patient's explicit consent to support them in following up on the second dose. So I say, my team and I would like to support you in making sure that you can get the second dose within the recommended interval. I hope that it's all right, that one of us will reach out to you and make sure that you're able to access it and see how we can support you. And then I work with a team that includes nursing staff and MAs, and we work to provide reminders to patients. And it can be within the EMR, you can embed a reminder that pops up for, and that way avoid overburdening workflows. I think really the gold standard is to embed standardized workflows. So schedule the second dose before the patient leaves, have standing orders, for example, coordinate follow-up with pharmacy. And then again, offering flexible scheduling, alternate vaccination sites also helps ensure patients complete the two-dose series. But it is really hard to remember that second dose, and it's normal that we need to support patients in that.
Great. You know, you mentioned embedding like ticklers in the EMR, reminders, or making it, the workflow frictionless. So how do reminder systems, like for the patient, even for automated texts or phone calls, portal alerts, can you talk a little bit about how that impacts the patient follow through and the completion rates for that second dose of the recombinant Zoster vaccine?
Absolutely. So reminder systems, and what we mean by this are automated texts, phone calls, or patient portal alerts, can significantly improve follow through and completion of the second dose, depending on the patient. And they do this through reducing forgetfulness, clarifying timing, and prompting timely action. Of course, it's important to couple a reminder like this with at some point a conversation with the clinician so that this doesn't come out of nowhere, because patients may not feel comfortable following up on a reminder for something that they never quite registered in the first place. But if we have had a conversation with the patient and then we deliver reminders at predefined intervals, this enables them to easily reschedule appointments, confirm appointments, and this closes the gaps between doses. This also is a way to reinforce recommendations that clinicians have already provided and normalize series completion as part of the many aspects of routine care that we're always reminding our patients about. So when these reminders are coupled with clinician conversations and integrated within the EHR workflows, as well as some brief educational messaging, they can increase completion rates and address logistical barriers and also sustain patient engagement so that we can get through the second dose of the two-dose schedule.
That's great. I'm going to turn back to you now, Dr. Hahn. In what ways do standing orders and protocol-driven workflows help streamline the shingles vaccination and reduce these missed opportunities for completing that two-step zoster dose?
Yes, definitely. And Dr. Randall has alluded to this already. I think the best practice is really to have standardized workflows, protocols, and standing orders that operationalize the point of care vaccination during routine visits, and ensuring that providers are consistently screening for vaccination and acting upon patients who might be eligible or within a single encounter. And technology has really allowed us to do so much more effectively, including the integration of alerts within electronic health records or clinical decision support systems. It can help to facilitate this standardized and consistent workflow when it comes to screening for vaccine eligibility. And having standing orders in place are also important. These are essentially prescription orders that are not limited to a specific patient and allow other healthcare providers like nurses or pharmacists to administer vaccines to eligible patients without having to wait for a separate individual physician order, which sometimes might be a rate limiting step. And professional organizations, including ACIP, do recommend using standing orders to improve vaccination rates. And certainly this is something that we can leverage upon as well to improve shingles vaccination.
This is great. I love having a multidisciplinary panel because you, as a pharmacist, Dr. Han, and we know too, that pharmacies can be great partners in the preventive care of patients across the board. How do partnerships and pharmacist-led vaccination programs improve access and completion of the two-dose Zoster vaccine series, particularly for patients facing scheduling and access issues?
Yeah, indeed. Many patients receive their vaccines at their local pharmacies, and partnering with pharmacies is a great way to improve access to the shingles vaccine and other types of vaccines as well. We have already talked about how working with your local pharmacies to make sure that the vaccine is in stock and available to patients is an important step. And also work with pharmacies to ensure that they have the appropriate standing order or collaborative practice agreements in place that allows them to administer the shingles vaccine to eligible patients. Additionally, pharmacies themselves can also leverage on their own IT system to improve shingles vaccination completion rates. And a large community pharmacy chain has actually published on this experience where they implemented a nudge system within the pharmacy's clinical decision support system that alerts all pharmacy staff of patients' eligibility for a second dose. And such systems have documented an improvement in the two-dose series completion rates.
That's great information. Dr. Han and Dr. Rendell, I want to thank you so much for your time today and sharing this excellent information with our viewers. I want to thank American Heart Association. Stay tuned for our next and final vodcast. This series is available through major podcast platforms. To claim credit, visit learn.heart.org.